I will start with some historical comments, then I will lose some words on 4 pillars, drug policy. I bring the whole thing together with Maslow's needs and addiction, and how it fits into harm reduction principles and therapy, and show you some surveys and a new project that started in April of this year. Actually, the Safe Injecting Facility, as we do it, a supervised center, was first presented at the first harm reduction conference in Liverpool in 1990. This year, we also visited in January in 1990 John Marks, which was quite influential at the time for us because of his heroin prescription. And also at this first international conference, there was the first presentation in English on the 4 pillars drug policy by Philippe Lehmann. He worked at the time for the Federal Office of Public Health. And in a small room, I presented the Fixerstübli, as we called it at that time, Safe Injecting Facility. Just to remember you, harm reduction at this time was very much civil disobedience, and we called it an intermediate strategy until we could end the prohibition as the main principle in drug policy. There were European movements or even worldwide movements at the time, like the European movement for the normalization of drug policy. This was run by Wijnand Sengers. He was a psychiatrist in Rotterdam. And then also an international league against prohibition existed. We had a Swiss section also of this international league, of which I was president. But these movements, they just passed away. Now, of course, it was not an invention from scrap, what we do in Bern. There were some roots of these drug consumption rooms, safe injecting facility, or medical supervised injection center, as they are called in Australia. And one of the roots were the house dealers in the Netherlands. Very important also, needle exchange that was invented by Erich Fromberg. He did not invent it for HIV, but for hepatitis C, which really makes sense. Then there was a facility called Berne Safer in Rotterdam. It was different from this Berne to our safe injecting facility room was that the injecting happened behind closed doors in the toilet. And there was the Prinsenhof in Amsterdam, which was run at the time by Franz Trautmann, whom you may know. This was a housing project where people were allowed to inject within the housing. And then the first drug consumption room worldwide of the new type, a place where there is a supervision of the whole room, including the injection, which is really the new thing and the really first. It didn't exist anywhere. In 86 in Bern. Of course, we had also these self-governed rooms, injecting rooms by users, a couple of years earlier in Zurich, but all these were closed, and our room since 1986 is running without a pause. It's continuous off. Now, 4 pillars drug policy was in a way a major achievement. We had the 3 pillars: prevention, therapy, and repression, and then politically, we just don't know how it worked, but the 4th pillar, harm reduction, was introduced. It took quite a long time until it really got a place in the law. And in the law, it's only since this summer. 4 pillars drug policy had many positive consequences for the individuals and society. However, there was also some negative consequences because finally it helped the prohibition to have a more humane look and enabled the system to continue. And on the other hand, also it gave new credibility for the so far 3 pillars which were not very effective in the end. Just to show you how, in my opinion, this works. Abstinence treatment, I'm not against abstinence. If someone really wants to go into abstinence, it's beautiful, and if they manage to reach abstinence, I'm happy with these people. But abstinence treatment means you have to be first abstinent as a prerequisite, and then it's also a treatment goal. It means you have to stop the symptom of drug use before treatment, and treatment finally is meant for stopping using. Then you have high relapse rates. You can find it in scientific literature everywhere. Success is hardly affected by the type of treatment. It's always the same. They promise you that the treatment will heal you, which is not told. And if you look at it at a population level, there is little impact of all this treatment. This is basically not very new. In the US, they had narcotic clinics between 1912 and 1923. And in these narcotic clinics, they were prescribing heroin, morphine by injection. And the concept of these clinics was that there is no permanent cure for addiction, but by prescribing you can stop illegal trafficking just by the legal supply. You can prevent people from being victims. You can prevent more new addicts just by breaking the pyramid selling system in a type of Tupperware selling. John Marx in 1990 always said every addict leads to 5 more new addicts just by the pyramid selling. I don't know if it's true, but basically it leads to more addicts. And finally, it will end petty crime and other criminality. For political reasons, this was stopped in 1923, and the only thing for many decades in the US was Lexington, a kind of prison treatment hospital. Mary Nieswander worked in this facility in Lexington and was not very pleased by the success. So when she met Vincent Dole, they developed substitution treatment with methadone. Now, today in a new ordinance to narcotic law, we have a definition of harm reduction and its aims. It should improve the health state of the people, should facilitate access to the health system and welfare, and should give information out about forms of use with reduced risks, should support the entrance into substitution-assisted or abstinence-oriented treatment, should support the motivation for enduring abstinence from psychotropic substances. And now this is politics, and even if you talk about harm reduction, you have to put in abstinence, otherwise it will not be acceptable on a political level. And then I think that away from the individual is protecting third parties and the public space from negative consequences related to addiction. Now, I, as a doctor, I always ask myself, are there really 4 pillars? Maslow's, he presented a concept of hierarchy of needs. So starting with deficit needs, which means physiological needs, eating, drinking, and things like that. Then safety needs as a next step means safe places to stay, houses, and so on and so on, belonging needs, and it goes up to self-actualization. And he clearly says not everybody in this society really wants to reach this highest goal. Total self-actualization is for many humans never a goal. They are pleased if they have TV set, the house, some beer in the fridge and things like that, and they don't ask for more. Now, in the principles of harm reduction, it means you have to cover a spectrum of needs, starting with the acceptation that many users initially won't give up their use. And if you really want to work with them, you have to first establish a contact. So this is the primary goal, even of the highest therapeutic alliance. And any reduction of harm is precious. It means if you really want to reach goals, you have to go up the pyramid, and you have to do it with small incremental steps and not starting first with the abstinence. This is a secondary goal in the best. It means also you have to work with the resources of your patients. Resources that can be used for changes, and then you have to enter into a collaboration of patient and treatment. Destigmatization of users is very important, but very difficult to fulfill. And if you really can motivate your patients, then almost anything is possible in a process. This means if you really want to treat patients, you have to integrate the needs of the patients, and you can clearly define stages of this treatment, starting with an initial contact, then you do an assessment, then you have to enter into a goal-finding process, and at last you have to support positive changes. This goes even into psychotherapy in the strictest sense. Harm reduction psychotherapy is not obliged to a single treatment school. It supports the process of self-transformation. It works with skill building, self-management, focus on explanation. Of course, you have to love your patients, empathy. And if a therapy doesn't reduce harm, it's not therapy. Just simple as that. Now, with opiate addiction, we know that nowadays that substitution-assisted treatment is highly effective in the sense that it reduces street heroin use, it reduces mortality and morbidity. It's effective in attracting addicts into the treatment system and stabilizing the patients. It's very cost effective. You have a high gain of QALYs for a cheap price. And if sufficient supply, if you really want to have sufficient supply, you have to work with GPs. For instance, countries like the US, where GPs are excluded from substitution treatment, you never reach the level where you have satisfying offer. Finally, it's about care and not cure. You remember what they said in the 20s of the last century, but care is a basic principle in all medical treatment. Now, again, back to the Maslow's pyramid. As you can see, in addiction, lowest level you really have to reach is the survival of the people. And if people do not survive, the rest cannot be reached. So on the top end of the whole thing, you always have to ask yourself, abstinence, is it realistic? Is there an indication? And in many cases, most of the cases of opiate addiction, the answer to these questions are primarily no. You start with substitution treatment better than just aiming at abstinence in the beginning. Now, question of course is opiate substitution treatment, is it therapy? Is it harm reduction? Is it high threshold? Is it low threshold? It's difficult to say. It can be all kinds of things. Now, the safe injecting facility in Berne, which also includes an inhaling room where people can smoke the drugs, has some changes over time. National coverage of safe injecting facilities in Switzerland is still quite low, so it attracts people from far, which leads to overcrowding. So locally in Berne we had to access limitation to implement, and over the time with the professionalization of the teams in the safe injecting facility and the treatment system, we had a gap. There was not much exchange between the two systems. In the beginning it was different because everybody from counseling and treatment was also working in the safe injecting facility, but this changed over the time. So I show you the figures from two surveys in 2002 and 2010. We found out that many of the clients in the safe injecting facility were actually in opiate substitution treatment. The figure is quite stable over the year, 2/3. As you can see, doesn't matter which substance, methadone, heroin. Subutex we had not in 2002 because this was not yet introduced into the market. There was one crazy person injecting in the safe injecting facility who was on naltrexone. I don't know what the idea was. Then, of course, we also wanted to know why are people being in opiate substitution treatment go to this facility. And one main reason was that they were using heroin and cocaine together. We call it cocktails. In English, it's rather speedballs. Then they were reporting on not satisfying effects of methadone, no rush, no warmth. Some of them, they had too low doses, probably not patients from our system, but from GPs. Then main problem, cocaine use, about 1/4. And then there were some saying they like heroin better. the missing of ritual of use, and then the last thing is which is quite difficult: frustration, social situation, loneliness, depression, which cannot be addressed totally by opiate substitution. Now, on the other hand, it means 1/3 of these patients are not in opiate substitution treatment. So we asked them if they would be willing to enter into substitution treatment if you offer this treatment in the safe injecting facility. Like if the prophet goes not to the mountain has to go to the prophet. And we developed a concept with a methadone dispensary in the localities of the safe injecting facility with uncomplicated intake, medical examination and indication, start of the methadone, up dosing the same day. And the limits we put on this was that they could only get it for 3 months, then had to be referred to our regular treatment. And we were not exceeding the dose of 100 milligrams a day. I put the figures together by the end of August. We had 11 entries, 10 males, 1 female. 6 of them got quite quickly referred to the regular center. 2 had to go to prison. 1 person decided to go on detox, and at the time 2 were still in the facility. Now, finally, I would say harm reduction is not a pillar by itself. It's a trans-sectional issue. Thank you for your attention.